drugs, it's important. I don't typically mention things like propofol or the type of gas I've given unless they ask. But, I think propofol is pretty standard. I will mention if we don't give it, because maybe they have an allergy of some kind, or maybe their EF was so low that we use etomidate instead. I'll definitely mention things like that. Versed, I always tell them because it can make them groggy. Sometimes people lose days of their life because of Versed.
Yes.
You never know how sensitive someone is, and they'll be like, they don't even remember that they even came. They'll be like, "Did I just have surgery?" And they'll ask you that question over and over, and you're like, "Yes." So
Yes.
it can really send some people for a loop. Other
Hmm.
people, it's like nothing happened, right? So
Right.
I tend to let them know when's the last dose of Versed, or if I had to give it even in an emergence, because maybe I anticipated more of a wild emergence. Same thing with Precedex. If I gave
Mhm.
Precedex towards the end, I will always let the handoff nurse know that. Last dose of fentanyl, Dilaudid, things of that nature, morphine, any kind of opioids. Um,
Mhm.
Definitely ketamine. Ketamine can come with a lot of side effects, such as hallucination. Now, Versed can usually help with that, but ketamine is important because, well, A, it's a great drug. It really helps not decrease that respiratory drive. It takes away pain,
Mhm.
but if a patient starts saying they see ants on the wall or they're itching their skin till it bleeds, like there could be something going on. They'd be like, "What's going on?" But the ketamine would be the explanation there. Sucks, great point with the MH. To be triggered for that. Also, sucks tends to be given to you guys for like airway, not airway emergencies, but difficult airways or risk of aspiration. So it's also and it probably alerts the PACU nurse, say, "Oh, was there a problem? Why did they get sucks? Was there a risk of aspiration? And is it something I need to be aware of as a PACU nurse? They could vomit on me." Or,
Mhm.
again, the MH thing, or is there an airway issue that I need to know about? So I think it's great that you would pass on something like sucks. And then Toradol,
And
Tylenol.
also,
Oh, go ahead.
well, and on sucks while we're talking about it,
Mhm.
it's also one of the number one causes of myalgias
Mm,
afterwards.
great
Just
point.
muscle aches.
Thank you.
So if they wake up and they're just like, "Oh, I ache everywhere," it
Mhm.
could be from the sucks.
Yes, and that's also there's some contradictory studies out there where a little bit of a priming dose of rock can combat that myalgia, but
Okay.
I've heard that it can, and I've heard that it doesn't. So in clinical, I haven't, obviously, since I don't take care of them in the full blown recovery, I haven't seen a significant difference. But I also haven't had too many patients complain about the myalgia. It will be the younger, more muscular people who complain if it were
Mhm.
to happen. But they've been supposedly, if you use a priming dose of rock, which is like 5 milligrams, you guys, before you give sucks, you won't get the fasciculations when the sucks kicks in, and so it supposedly decreases the risk of the muscle fatigue afterwards. Gabapentin, Celebrex, same thing for like post-op sleepiness. That can really play into that picture. Toradol, Tylenol for post-op medication. Toradol, it's one of those drugs where, again, be cognizant in patients who are high risk for bleeding or who are severe
Yeah.
asthmatics. Um, but yeah, they need to know when they can give medications that also have these drugs in it, NSAIDs and things like Tylenol. I'm trying to think what else about the reversal. Not much there to report on. I usually let them know I reversed them. The one thing that I want to point about reversal, you guys, is you can have 4 twitches and have 70% blockade. And Kathy, you probably,
Really?
yes, I didn't know. I wasn't, so you probably are aware
I
of
didn't know that.
that. Oh yeah, and so in most healthy people, 70% blockade of your muscle receptors are not going to actually cause any issues, which is incredible if you think about that.
Wow.
But in patients who are a little more compromised, who maybe have some respiratory issues or just a little more, um, older, elderly, it can cause a significant issue where they might be desatting and have to take deep breaths, and it could be because of residual paralytic that was not adequately reversed.
Yeah.
Um, these are things to be very cognizant of, you guys, as you're practicing anesthesia, and don't ever be afraid to give a little bit of reversal. I've had people say, "Oh, we don't want to give it if you don't have to, there's side effects." But if you match your neostigmine with Robenal, technically, and especially if you're just giving 1 and 1 or something like that, just enough to cover any, if it's been 4 hours since you last gave it, if you just give a little bit, it'll cover anything that's left over, because you could still have some residual. I don't know. I'm not someone who holds back from giving it
Yeah.
at
Yeah,
these.
and neostigmine is the longer acting, longer to take effect. Sugammadex is the quicker reversal. In your practice, I haven't seen needing to give additional reversal after Sugammadex. Have you needed to do that after that?
Yes, I have, but it usually happens so quickly that you usually handle it back in the operating room.
Okay.
Versus neostigmine. Now, the problem with neostigmine is if you only have one twitch when you give it and you give the full dose, which there's always a maximum dose you can ever give, you could actually cause more weakness depending on, it's not honestly like the best drug, but it's what we have. But it can kind of cause a mixed where you almost kind of get a reverse blockade, but patients can be weak. And like you said, it not only is it slow to kick in, but it can wear off. And technically, if they had that full blockade when it was given, they could become weak again, technically. But I don't think it's super common, but I'm sure it can happen.
Yeah.
Sugammadex, on the other hand, it's very quick on and it's quick to fully reverse rocuronium type of paralytic, which is the majority of what we use. It's not as effective in vacuronium, but it can be. But rocuronium is like the main drug that it reverses. But that being said, if they have no twitches, you really have to go to that max dose of Sugammadex to truly reverse it, and which can be a pretty big dose, milligram wise. But yeah, so I haven't seen people need it in PACU again. Definitely in the OR, I have seen it only like once, and that was for a procedure that the surgeon literally needed them to have 0 out of 0 twitches up until they were done. And when they were done, it was like undock the robot, boom, 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 suture, suture, done. And I was like, I don't have time to have the rock wear off at all.
Right.
So that was where that occurred. But yeah, post-op nausea, this is good to let them too know, you guys, if they have a history of it.
Yes.
If they don't, well, obviously you still give them Zofran more likely anyways. But for me, Phenergan has always been the best rescue drug.
Yeah, Phenergan's good. Makes them sleepy though.
Yes, exactly. But prevention is always key. But I feel like once you actually get active nausea, Zofran doesn't really do a whole lot. Phenergan always does. But again, I usually give a very small dose because otherwise it will knock you back out. In combination, especially with drugs like Versed, fentanyl, things like that. Scopolamine is a great drug. You should let patients know that they can leave it on for 3 days and not to touch their eyes after they've had it on their hands, because it can dilate their pupils and give them blurry vision. Trying to think, hemodynamics we talked about.
The elderly with scopolamine, if they have any emergence delirium, then we take it off in the PACU because it can worsen the emergence delirium with the scope patch.
I love that. Good point. PACU intervention. Oh, go ahead.
Oh, I didn't talk about TXA there, but I've got TXA next to the antibiotic. We usually give another dose of TXA, another gram after our total joints in the PACU before they go home.
Yes, thank you for that. I didn't see it either, even though it's right there. An antibiotic, good point. You want to let them know when the last time they got their antibiotic or if they were due for a next dose of antibiotics. And same thing with the TXA, when you last gave it and how, and all surgeons are different on TXA. I would say most of them give it, prior to incision and then also with closure. But again, passing that type of thing on to the recovery room nurse. Input, output, always really huge that you have to let them know. I don't typically know. I don't usually give normal saline. I don't know who would give normal saline, but I'm sure there's a use for it. I just 99% of the time always use LR because too much normal saline can cause the hyperchloremic metabolic acidosis. If you're giving blood, you want to give normal saline because there's not as many electrolytes that can interact with the blood like calcium. But I did open heart for 4.5 years and we always used LR with blood and never had any issues. So it was pretty standard. We still didn't use saline. It was just, they were like, that's like garbage. Don't give it. So
it's very uncommon. But there was sometimes, and now if they're a renal failure patient, then you would do like saline instead of LR for them. But it is very uncommon to see saline in this population, the surgical population.
Yeah, good point. Yeah, renal failure is definitely a population we'd always use normal saline, but usually it's a 500 bag and we'd be very careful to not even give the whole thing. But those can be challenging cases because they come in dry, and they just had dialysis and their blood pressure, they don't tolerate, they're usually under max. I mean, generals with renal failure patients are a lot trickier and harder to manage, especially post-operatively. And usually you have to schedule dialysis and things of that nature. Those are all things that you would do pre-op, you guys, to kind of plan for this type of case. Blood, you definitely want to make sure what type, not just that they got blood, but what types of blood products, and then how much and when, and also any labs that again would correlate with the last ABG after they just got the last unit of blood. So maybe you did a tag, right? And maybe the results of the last tag too would be also important. Lines, peripheral IVs, A lines, any other kind of central lines. If they have sheaths, when they have sheaths coming from, EP lab and things of that nature, these are things that, again, the OR nurse or the fellow tend to report on. But it's also your responsibility to make sure that the nurse is aware of that. Those are something that they have to manage and keep a close eye on, because there's a risk for bleeding. They can't sit up. They have to lay flat for a certain period of time. And so making sure those things are all communicated, even though there should be someone else to help you do those types of handoffs. Also, at the end of the day, you have to do everything. You have to make sure everything has been addressed. You can't just say, well, that's not my thing. But I will say that most time you're supported in that realm. But you get familiar with the handoff because you'll listen to it so many times when they're going over the venous access, that if something gets dropped or the ball gets dropped and it doesn't happen, you can jump in and help the PACU nurse with that part of the report.
Yeah, just to chime in, one of the hospitals I worked at, when we would get the patients from the cath lab, they had a yellow report sheet. So it wasn't white, it was yellow so that it stood out. And it would have like right groin, left groin, arterial, venous,
Nice.
the size of the sheath, the pull time, the closure device, the hemostasis time, the ACT, the last protamine dose. So it had all of those things to make sure that you knew how much drugs they had, the reversals for the heparin, the protamine, how they closed, if it was a star close or a per close, or it was a manual pressure.
Those are things that always trips me up. I'm like, I don't remember what closure device it was.
Yeah, usually if it's manual pressure, it's a 6-hour bed rest. If it's an arterial closure device, it's like 2 to 3 hours, depending on the product. If it's a venous closure device, then it's like 1 to 2 hours, depending on the product. But don't hold me, you need to know what your hospital's using and what your docs order for those times. But, if it opens up, you're back to manual pressure, and then you're back to the 6-hour bed rest, and you're holding pressure. And, maybe they need another dose of protamine. You probably need to, let anesthesia and the team know, the cardiac provider, surgeon, because I've seen horrible pseudoaneurysms, arterial occlusive bleeding. It can be bad. And I worked in IR for years, and we were really good in IR, but once they left us, you just don't know the knowledge level. And sometimes it can be just a capillary bed bleed where it's just superficial and it's not actually like the femoral artery, or it could be the femoral artery. And, you can have a retroperitoneal bleed from that if it's not addressed quickly.
That's scary.
Yeah, it can be scary. Yeah. So, and there's hemostatic dressings like D-Stat, HemeCon are some of the ones that are out on the market. So if you get a bleeder, I like to keep those in the PACU, especially for that patient population that's coming from the cath lab, just so that we can, because sometimes it's just that there's superficial capillary beds. I've even seen one hospital do local lido with epi injections around it to just manage that superficial bleeding. So it really depends on what your facility does and what the protocol is for managing those bleeds if they rebleed.
Yeah, good. Thank you for covering that. Yeah, they and you guys, when they have to hold manual pressure, it does not feel good. I mean, patients do not like it because it hurts. So yeah, making sure that you address it quickly, whether they need more protamine. I would say, like, before we ever leave the cath lab, usually it's needing more protamine of some kind. And usually if we're questioning at all, we give a little bit more just to dry them up a little bit. And then the other big thing is just making sure the patient is aware after anesthetic that to be still, which can be hard when they're a little bit delirious, still a little disoriented. They want to sit up, they want to move around, they want to turn on their side. I'm like, no. So it's trying to reorient them as quickly as possible so they know to hold still and not lift the legs.
I'm a little nurse ratchet on that. I'm like, no coughing, no laughing, no sneezing, no crossing your legs, no wiggles. And then I want to know, when was their last void? Were they straight cathed? Because that is like the biggest thing for us, for the nurses, is, if they've got a full bladder. I mean, I've had a guy like 6 foot, with 4 sheaths that were pulled, and I'm trying to keep hemostasis on his groins, and he's trying to climb out of bed because he's got to go pee.
Mm-hmm.
So, making sure
Yeah.
that they get, straight cath at the end of the case, so that we don't have to deal with that. When I worked in IR and we would have our strokes, we heparinize, we would do intra-arterial TPA to get the clots out, like the MCA, those embolic strokes. And we used a bunch of heparin to prevent, clots from forming on all those sheaths or the catheters. And yeah, so we would give a bunch of protamine at the end and just make sure, and we would also straight cath them, just to make sure that we emptied the bladder so that people aren't trying to get up out of bed.
Mm-hmm. As an anesthesia provider, you guys, you can play a role in this because you can know, hey, had to give them a liter of fluid. They're going to have to pee. And sometimes those cases, they go for so long that even if you don't give them a lot of fluid per hour, you end up giving them a lot of fluid overall because it's a long case. Those are really good cases to straight cath because, like Kathy pointed out, and they wake up combative because they're in pain because the full bladder causes pain. And you'll see that a lot with like elderly men. I feel like I saw that a lot where they wake up combative and agitated, and it's usually because they have to pee. So
yeah, it can add to the emergence delirium for the post-operative urinary retention. Once that bladder gets so large, the detrusor muscle in the bladder, it gets overstretched, and then they can't pee, they can't recoil it, and so you have to straight cath them because of that retention. So yeah, we've seen some big retainers. So
I'm sure
I don't hesitate. I'm like, hold them down. We're just capping them.
Right. Let's kind of wrap this up with what are some common mistakes that that nurses should avoid during PACU handoff?
I think the biggest thing is don't interrupt. Let everyone have their chance to, I think everybody, to backpedal it, you need to have a system. You need to have a process in place. So that's the first mistake if there's no process in place. Getting the surgical team, the anesthesia team, and the nursing team together and saying, this is what we're going to agree upon for report, and then roll it out and trial it. One of the hospitals, they ended up laminating the report process because everybody was getting frustrated with interruptions. Because you would have a nurse say, well, what about this? And what about this? And what about this? And he'd be like, well, if you just give me a moment, I'll tell you all of that. So they laminated it, put it above the bed, and it was the process of, it was quiet, like no interruptions. And that also means from like everybody coming to help get them settled. The anesthesia provider and the PACU nurse face to face, and the anesthesia provider says, are you ready for report? And then they say yes. And sometimes the PACU nurse wants to get them on the monitor, which is fair, and get those baseline vitals. So, getting them connected, getting their oxygen on, getting your baseline vitals. And then once you've got your EMR opened up, then you can say, okay, we're ready for report. And then letting your anesthesia provider give you report. And then wait for them to finish. And then they say, do you have any questions? And then that's when the PACU nurse can start asking questions. And then they can say, are you satisfied? And then the PACU nurse can say yes. But also the OR nurse usually jumps in during that process once the anesthesia provider is completed. And they will do like the local, like you said, and the dressing. And usually it's really, I recommend that the PACU nurse looks at the dressing, assesses the dressing with the OR nurse while the anesthesiologist or the CRNA is still there, making sure we don't have any bleeding. The dressing didn't, get pulled off on transfer. The drain didn't get, dislodged or any of those things, and so it can be addressed right then and there. So the OR nurse gives their report, and then the PACU nurse should be able to safely accept that report.
No, I love that. And I love the fact that you mentioned vitals. You guys, that is also, I always jump in and put them on the monitor. I just help with it. Don't stand there and watch them struggle with that. Now, depending on, some PACUs will have more than one nurse who comes over and tucks in a patient. And so they usually have extra hands. Not all places do. Sometimes it's just one PACU nurse trying to tuck in the patient. And so help them put them on the monitors, get them on the EKG, put the pulse ox in. And also because you will need those vitals for your handoff anyways, for your own charting. So helping speed that process along helps. And yeah, you're right. We typically drop them off, get them hooked in the monitors, make sure their O2 is okay, that they're comfortable, that warm blankets, take care of the patient first, always the patient first, and then the handoff. And yeah, I usually always say, you know, are you ready for a report? Because again, like you said, they want to pull up in their medical record and make sure that everything's squared away. If the patient's combative, having pain, you address that right then and there. You don't start giving a report while the patient's screaming in agony or rolling over the bed, ripping out their IVs. You always address the patient first. But I think that's a really great point to point that out, to the communication. And yeah, not being interrupted during it would be, luckily, I don't think I've ever had too many issues with that. Not usually from the PACU nurse. It's usually from like, you know, like a resident or something that usually interrupts or something like that. But I feel like if you all gather at the bedside at the same time, I feel like anesthesia usually gets to go first. I don't care if the resident wants to go first, but I clearly look at that resident and say, go ahead, you know, because they're clearly waiting too. And usually they're very quick. And they have to get back to the room to finish up the post-operative note. So I usually say, yeah, go ahead. And the resident talks. Sometimes depending on the OR nurse, same thing. I say, yeah, go ahead, you know, just because I really should be the last one to leave the bedside. Anesthesia should always be the last one to leave the bedside. I know that might not feel good to you because you have stuff to get back in the room and do, but you want to make sure you're the last set of eyes that's on that patient. And that way you can circle back around and address any pain needs before you leave. Because again, they may have to still get orders settled and everything you have dilaudid, extra dilaudid. I always ask before I leave, are you good? And do you want any additional pain medication? Are you happy with the way they look? Because you can give that extra pain medicine and help them out. And
so all of my PACU situations have been in non-teaching hospitals. So don't have the med students or residents there. When I did ICU, I was in a teaching hospital. But so our surgeons, they will come out and they go right over and start dictating while the report is happening with the PACU nurse and the anesthesia provider. And then usually once they're done dictating, then they'll come over and they'll, you know, check the dressing, ask if we have any questions. And then that's when, you know, like if they have high blood pressure or you know, like if it's maybe a neuro patient or something like that, like, you know, specific things, I'll ask them, what are your parameters for certain things? Or they always give you a chance to ask a question before they go start their next case. It should be. So like if the multi-level spinal fusions and things like that, they'll want to look at that dressing one more time before they go back in and start the next case, just to make sure that there's no hematoma forming or anything like that. It does depend on where you work, but yeah, in the community hospitals, they're always right there, usually dictating, and they've got eyes on their patient while they're, you know, they're looking up and they're making sure that the patient's breathing, they're checking their vitals, because they've got to put it in on their dictation note for the post-surgical note.
Yeah, great. Well, the last thing I want to mention for those of you listening, if you're taking a patient, other than PACU, if you're taking them to like the ICU for handoff, make sure you're always packing a travel kit. You want an extra airway, a blade, some propofol, some emergency drugs. You always want to make sure you're traveling with that in mind. And so that is one thing that, you know, if you get very familiar and comfortable traveling in the PACU and it's right down the hall, but now you have to haul a patient to ICU, sometimes it's hard to get that habit of taking those transport drugs. But think about it like when you're back in the ICU and you're transporting a patient, you always had emergency drugs and supplies. Same thing applies in anesthesia. I guess we'll kind of just wrap this up too with just be patient with the process. I think this can be overwhelming at first. You can feel like you're fiddling through it. Never hesitate to ask the PACU nurse if you left anything out. They will tell you. And, you know, they understand. There's also been times too, you guys, and I'm experienced and I do it, but I'll like give a drug right before I leave the OR, but my chart will already be closed. So I'll just think I'll chart it in PACU, but then I forget, you know, and so that does happen. And they're like, you said you gave this much dilaudid, but only this much is charted. And I'm like, oh, thank you. Or I'll have to do it after the fact. Or there's times where I forget to document that I already removed the oral airway. Because maybe they had it in and, you know, maybe either in PACU or on the way over, I take it out or right before I leave the room. And they see it still in on their documentation. And so trying to be thorough with your charting. Obviously the PACU nurses get to know you and they can give you some forgiveness, but it's really key to try to be as thorough as you can to make sure you're tidying up your chart, making sure all your drugs are charted that you gave, and trying to do that prior to even leaving the operating room, trying to do that as you're wrapping up the case. which again can be hard if it's a rapid turnover case, but do the best you can and be open in your communication and be patient with yourself as far as getting into a groove. But Kathy, thank you so very much. You were awesome and shared so much wonderful insight. And how can our listeners connect with you?
Thanks, Jenny, for having me. It was a pleasure. And you brought in so much insight too. It's great to bring the two sides together.
Yes.
So thanks for the opportunity. I think it's going to be really valuable for your CRNA students. And I think for the new PACU nurses and even experienced PACU nurses, looking to streamline that safe handoff communication. So if people want to utilize this tool, they can go to PACUNursingMinutes.com, and just halfway down the page is the free handoff, and just click on that and it'll bring you to the page where you just plug in your name and your email, and then it will go right to your inbox.
Awesome.
So thanks again for the opportunity to share it with your teams. And yeah, I look forward to seeing how people implement it, and hopefully somebody will use it for their DNP project. So
I sure hope so too. I hope our listeners are taking notes on that. Thank you so very much. This was wonderful. We'll have you on the show again later.
You're welcome, Jenny.